Right. So we shall start with extractions of the maxillary teeth. So starting with the left maxillary central incisor, you will apply your forceps labiopalatally and then apical pressure. Maintaining this apical pressure, you will rotate the tooth mesially, go back, mesially, go back, and once the tooth is sufficiently loose, you can deliver it in a labio-occlusal direction. Check that the tooth has been extracted completely with the root. Place the tooth back onto your surgical tray. Examine the socket that it is free from debris, any broken tooth fragments, etc. And in real life, you will irrigate the socket with sterile saline. And after that, you can place a gauze piece, roll it into a sausage, and then place it directly onto the extraction socket, asking the patient to close their mouth for 10 minutes. And then this should be adequate to achieve hemostasis. And then you can remove the bite pack, check there is a stable clot in the socket, and then you can discharge the patient with the post-operative instructions and write your clinical notes. So I'm just going to place this tooth back in the socket, and you need to do the same for all extractions you do on these models. Otherwise, you will have an assortment of teeth and you will struggle to put them back in the right place. So that's for the central incisor. For the lateral incisor has a slight apical curvature on the root, slight palatal curvature on the apical third of the root. So the same movements are not ideal for the lateral incisor. So we start with apical pressure and then we move the tooth slightly labially to loosen it a little bit. And once the tooth is loose, maintaining the apical pressure, then you can afford a little bit of rotation. So with a combination of rotation and labial displacement, you can deliver the tooth in a labio-occlusal direction. Okay, take your time, deliver it in a labio-occlusal direction. So that's for the lateral incisor. The rest of the procedure with hemostasis, everything stays the same. For the maxillary canine, you can use the anterior forceps with the broader blade. And the canine, as you know, maxillary canine has one of the longest roots. So again, you need to expand the socket first before carrying out specific tooth movements. So apical pressure, you will start with apical pressure. And here what you do is you move the tooth slightly labially and palatally to expand the socket. Then you can afford a little bit of rotation. It's a single rooted tooth, but the root can be quite massive. So once the tooth is sufficiently loose, you can withdraw it in a labio-occlusal direction. So this is for the single rooted teeth. Now the maxillary first premolar usually has a buccal and a palatal root. So rotation is not ideal for the maxillary premolar. And what you would need to do here is you would have to modify your movements to buccopalatal movements. So again, apply the forceps apical pressure, and maintaining this apical pressure, you will move the tooth buccally, palatally, buccally, palatally, buccally, palatally, buccally, palatally. And once the tooth is sufficiently loose, you can withdraw it in a bucco-occlusal direction. Okay, check that you've extracted both the buccal and the palatal root, and the rest of the procedure is same as for the other teeth in terms of placing a bite pack, achieving hemostasis, etc. The maxillary second premolar usually has one root, and what you can do is you can use a combination of buccopalatal displacement and rotation, and there is less risk of root fracture. So again, apply the forceps, apical pressure, and then you can move the tooth buccopalatally, as well as you can afford a little bit of rotation. You can use a combination of the two movements. So you can see we're extracting the maxillary left second premolar, or 2-5, and once the tooth is sufficiently loose, you can withdraw it in a bucco-occlusal direction. And don't be shy to readjust your forceps if they are slipping. That's very normal. So make sure you always adapt the forceps correctly. So buccal, palatal, and withdraw it in a bucco-occlusal direction. And with my non-dominant hand, I can actually feel the movement of the root within the bone, which is very helpful, so you know what the tooth wants to do. Check the roots, check the socket, place a bite pack, and the rest of the procedure is the same. And finally, we shall now look at extracting the maxillary molar tooth. So on this occasion, we will extract the maxillary, left maxillary first molar, and you can see that I will ensure that the beak rests in the buccal groove. So I've got the correct forceps, because when I apply, the beak will rest in the buccal groove on the maxillary first molar. So you have to be careful with the maxillary teeth, because their closed maxillary molars are close to the floor of the antrum, and whilst you will maintain an apical pressure, you have to be a bit more gentle, because if you apply too much pressure, you can actually fracture the floor of the antrum, leading to an oroantral communication. So apical pressure, and what you will need to do here is you will need to carry out buccopalatal displacement, because the maxillary molars, first molars and second molars, they have three roots, two buccal, one palatal, and the palatal is the largest. So you need to move the tooth buccopalatally, maintaining the apical pressure buccopalatally. And once the tooth is sufficiently loose, you can withdraw it in a bucco-occlusal direction. And as I said, don't be shy to readjust the grip of your forceps, because these are metal teeth and it's easy for these to slip through. Check the roots. You can see one large palatal root and two buccal roots, the mesiobuccal and the distobuccal. So that completes the procedure for the maxillary second molars, and fully erupted maxillary third molars is the same. It's the same buccopalatal displacement and withdrawal in a bucco-occlusal direction. So that completes the maxillary teeth. Next we shall look at the mandibular teeth.